a cardiac surgeon wants you to know about your sleep position. You've probably heard that sleeping on your left side is good for your heart, or that sleeping on your back can worsen snoring. But what if the way you sleep every single night could quietly raise your risk of a stroke, not over decades, but overnight? According to a growing number of cardiac surgeons and vascular neurologists, one common sleeping position may do exactly that. And the warning isn't theoretical. It's based on how blood flows, how gravity works, and how the anatomy of your neck and chest interacts with rest. The position in question is sleeping flat on your back with the head and neck poorly aligned, and in some cases, even sleeping on the wrong side for certain vulnerable individuals. Let's be clear from the start. For most healthy people, sleeping position alone will not cause a stroke. But for those with underlying risk factors, undiagnosed atrial fibrillation, carotid artery plaque, severe sleep apnea, or venous compression syndromes, the position you hold for 6 to 8 hours a night can become a physiological trigger. This article explores exactly why cardiac surgeons are raising their voices, what happens inside your body while you sleep supine or in a rotated neck posture, and how small changes to your sleep habits could reduce your overnight stroke risk. The anatomy of overnight stroke. To understand why sleep position matters, you first have to understand something unsettling. Strokes don't always announce themselves during waking hours. In fact, a significant percentage of ischemic strokes, the kind caused by a blood clot blocking blood flow to the brain, occur either during sleep or within the first hour after waking. These are called wake-up strokes. Research published in neurology and stroke journals estimates that roughly 1 in 4 ischemic strokes happens during sleep. When a patient wakes up with stroke symptoms, doctors often have to estimate the last known normal time, which complicates treatment decisions like administering clot-busting drugs. So what changes during sleep? Blood pressure naturally dips. Heart rate slows. Hydration levels drop after hours without water. Blood becomes slightly more viscous. And if you add a mechanical problem, like a compressed blood vessel in the neck, the stage is set for clot formation. Cardiac surgeons, who deal daily with the highways of blood flow arteries, veins, and the heart itself, are uniquely positioned to understand how posture affects circulation. They see patients who have everything from kinked carotid arteries to thoracic outlet syndrome, where blood vessels between the collarbone and first rib get compressed during certain arm or head positions. When you take those anatomical vulnerabilities and multiply them by 8 hours of unconscious stillness, you begin to see the concern. The offending position, supine with neck rotation or flexion. The position that draws the strongest warnings is sleeping flat on your back supine with the head turned sharply to one side or propped on a pillow that forces the chin toward the chest. Why is this dangerous for certain people? Let's walk through the mechanisms. 1. Carotid artery compression. Your carotid arteries run up both sides of your neck, delivering oxygen-rich blood to your brain. When you rotate your head more than 30 to 40 degrees and hold that position for hours, you can mechanically narrow one carotid artery. This is not theoretical. Ultrasound studies have shown measurable reductions in blood flow through the contralateral opposite side carotid when the head is turned. For a person with an already narrowed carotid artery due to atherosclerosis plaque buildup, adding positional narrowing can reduce flow enough to trigger symptoms, or worse, create turbulence that dislodges a piece of plaque, sending it downstream into the brain. Cardiac surgeons see this most clearly in patients who have undergone carotid endarterectomy plaque removal surgery. Those patients are explicitly warned not to sleep with their head turned toward the operated side for weeks after surgery, because the newly opened artery can collapse or kink. 2. Vertebral artery kinking. The vertebral arteries run through small holes in the cervical vertebrae, the bones of your neck, before joining together to supply the back of your brain, including the cerebellum and brainstem. Turning your head too far, or sleeping with a pillow that hyperextends or hyperflex your neck, can kink one or both vertebral arteries. In rare cases, this leads to what's called bow hunter's syndrome, where turning the head causes dizziness, double vision, or even transient loss of consciousness due to reduced blood flow to the brainstem. While that's usually a positional symptom that resolves when the head returns to neutral, imagine holding that kinked position for an entire night. The risk of a small clot forming at the kink point becomes real. 3. Venous outflow obstruction. Less talked about, but increasingly studied, is the effect of head and neck position on cerebral venous drainage. Blood doesn't just need to get to the brain, it also needs to leave. The internal jugular veins are the main exit routes. Sleeping flat on your back with your head turned can compress the jugular vein on the side you're turning away from. Slowed venous flow doesn't directly cause ischemic strokes, but it can raise intracranial pressure, worsen sleep apnea, and create a stagnant environment that promotes clotting in the venous system, leading to cerebral venous sinus thrombosis, a less common but serious type of stroke. What cardiac surgeons are seeing in the clinic? Dr. Jonathan Fisher, a retired cardiac surgeon and clinical educator, has spoken publicly about cases where patients with no major stroke risk factors woke up with devastating neurological deficits, and imaging showed no large vessel disease, no atrial fibrillation, and no clotting disorder. What they did show, in some cases, was evidence of repeated mechanical trauma to the carotid or vertebral artery from chronic, extreme head rotation during sleep. One case involved a 58-year-old man with well-controlled blood pressure and cholesterol who developed a vertebral artery dissection, a tear in the artery wall, after sleeping for years with his head cranked to the left, using 2 thick pillows. The dissection triggered a clot, and the clot caused a lateral medullary syndrome stroke, a classic Wallenberg syndrome with vertigo, swallowing difficulty, and facial numbness. The treating neurosurgeon noted that the patient's pillow stack had forced his neck into nearly 45 degrees of rotation and 20 degrees of flexion every night for more than a decade. That's over 30,000 hours of low-grade vascular stress. Cardiac surgeons emphasize that the heart and brain are connected not just through blood chemistry, but through plumbing. If you kink a garden hose for 8 hours a night, eventually the hose weakens. Arteries are far more resilient, but they are not immune to chronic mechanical strain. The atrial fibrillation connection. Another major link between sleep position and stroke risk involves atrial fibrillation AFib, an irregular, often rapid heart rhythm that dramatically increases stroke risk because it allows blood to pool and clot in the left atrium. Sleep apnea is a well-known trigger for AFib episodes. And sleep position directly affects sleep apnea severity. Sleeping on your back supine worsens obstructive sleep apnea for most people because gravity pulls the tongue, soft palate, and throat tissues backward, narrowing the airway. More apnea events mean more drops in blood oxygen, more surges in adrenaline, and more stress on the heart's electrical system, all of which can trigger paroxysmal AFib. Once AFib starts, even if it's brief, it can leave behind a clot that later travels to the brain. For patients with known AFib, cardiac surgeons and electrophysiologists often recommend sleeping on the side, specifically the left side, to reduce apnea severity and minimize vagal nerve stimulation that can trigger AFib. But here's the nuance. Some cardiologists now warn that for a small subset of AFib patients with enlarged atria or specific anatomical variants, sleeping on the left side can mechanically stretch the left atrium enough to trigger arrhythmias. This is still debated, but it highlights that no single position is perfect for everyone. Right side versus left side. Is there a difference? You'll often see wellness articles claiming that sleeping on your left side is best for your heart because it promotes lymphatic drainage and takes pressure off the aorta. There's some truth here, but it's oversimplified. From a stroke risk perspective, times left side sleeping may improve circulation for pregnant women, reducing compression of the inferior vena cava, and may reduce acid reflux, which is a separate risk factor for esophageal damage but not directly for stroke. Times right side sleeping may put more pressure on the vagus nerve for some people, potentially affecting heart rate, but no strong evidence links right side sleeping to increased stroke risk in the general population. The real danger isn't left versus right. It's extreme rotation and poor neck alignment in any position. Whether you're on your back, left side, or right side, if your head is cranked at an unnatural angle relative to your spine, you're putting mechanical stress on your cervical arteries. Cardiac surgeons who also treat thoracic outlet syndrome note that sleeping with an arm above the head, a common position for side sleepers, can compress the subclavian artery and vein, reducing blood flow to the arm and, in rare cases, creating a clot that can travel retrograde toward the brain if there's an anatomical variant called a bovine arch. Yes, that's rare. But rare means little to the person who wakes up with a stroke. Who should worry most? Let's separate alarm from action. The following groups should pay serious attention to sleep position. 1. People with known carotid artery stenosis narrowing, even if asymptomatic. Ultrasound findings of 50% or greater narrowing warrant a conversation with your doctor about sleep posture. 2. People with atrial fibrillation, especially paroxysmal AFib that seems to occur at night or early morning. 3. People with obstructive sleep apnea who have not yet achieved control with CPAP or other treatments. Supine sleeping worsens apnea. 4. People with cervical spine issues, herniated discs, bone spurs, or cervical arthritis, because these conditions can already be narrowing the vertebral artery foramina, the bony channels the arteries pass through. Adding poor sleep position can be the final straw. 5. People with connective tissue disorders, Ehlers-Danlos syndrome, Marfan syndrome. Their arteries are more stretchable and vulnerable to dissection from mechanical stress. 6. People who have had a prior cervical artery dissection, recurrence risk is real, and sleep position modification is a standard recommendation. If you don't fall into any of these categories, your absolute risk from sleep position is extremely low. But here's the catch: many people have undiagnosed carotid plaque, mild sleep apnea, or silent AFib. You might not know you're at risk until after an event. That's why cardiac surgeons argue for universal sleep hygiene principles that minimize unnecessary vascular stress, not because everyone will benefit equally, but because no one knows with certainty that they are immune. How to fix your sleep position without losing sleep. Changing how you sleep is famously difficult. You can't consciously control your posture for 8 hours. But you can change your environment and habits to make the safe position automatic, or at least more likely. 1. Rethink your pillow. Most pillows are too thick. A pillow that props your head up 4 to 6 inches when you're on your back forces your neck into flexion chin toward chest and often encourages rotation. 4. Side sleeping. The goal is to keep your head and neck in a straight line with your spine. Times back sleepers, use a very thin pillow or a contoured cervical pillow with a depression for the head. Your head should be neutral, not tilted up, not tilted down. Times side sleepers, the pillow height should match the distance from your neck to the edge of your shoulder. For most people, that's 3 to 5 inches. Your nose should align with the center of your sternum. 2. Create a no-turn zone. If you habitually sleep on your back with your head turned sharply to one side, try using a U-shaped travel pillow backwards, the open end facing the ceiling, to cradle your head and discourage rotation. Some patients use rolled towels placed along the sides of the head to create gentle resistance against turning. 3. Positional therapy for back sleeping. If you need to avoid supine sleep for sleep apnea or carotid concerns, you can train yourself to sleep on your side using times a tennis ball sewn into the back of a tight t-shirt, times commercial positional therapy devices that vibrate when you roll onto your back, times a wedge pillow that elevates your torso 30 degrees. Elevated supine is less dangerous than flat supine because gravity helps maintain airway patency and venous drainage. 4. Elevate the head of the bed. For patients with heart failure, AFib, or venous concerns, elevating the head of the bed by 15 to 30 degrees using blocks under the bed frame, not just pillows, reduces intracranial pressure and improves jugular venous outflow. This isn't about neck angle, it's about the entire body's relationship to gravity. 5. Check your morning symptoms. One practical clue: if you wake up with headaches, dizziness, blurred vision, or a feeling of pins and needles in your face or scalp that resolves within minutes of sitting up, record your sleep position. Those transient symptoms could be positional vertebrobasilar insufficiency, a warning sign worth taking to your doctor. The counterargument: when worry becomes overblown. To be fair, not all cardiac surgeons agree that sleep position is a major public health concern. Some argue that the evidence is largely case reports and small physiological studies, not large randomized trials. They point out that for every patient who had a dissection linked to sleep posture, thousands of people sleep in bad positions every night without incident. This is a reasonable counterpoint. Medicine must balance theoretical risk with practical anxiety. Telling millions of people to fear their pillow could create more harm: insomnia, anxiety, unnecessary imaging than benefit. However, the cardiac surgeons who do speak out are not trying to scare the healthy public. They are trying to reach the at-risk patient who doesn't know they're at risk, the 50-year-old with undiagnosed hypertension and mild carotid plaque who sleeps with 2 pillows and a twisted neck. That person could benefit from a small, cost-free change. And in a medical system where stroke remains the 5th leading cause of death and a leading cause of long-term disability, even modest risk reductions matter when aggregated across millions of people. What a cardiac surgeon would tell their own family. If you sat down with an experienced cardiac surgeon and asked, "What sleep position should I avoid, and what should I do instead?" Setting aside medical jargon and scare headlines, the answer would likely sound like this: don't sleep flat on your back with your head cranked to one side all night. That's the main thing. If you sleep on your side, keep your neck straight, same as standing. Use a pillow that supports, not bends. If you have heart disease, sleep apnea, or any history of stroke or TIA, talk to me about positional therapy. And don't ignore morning headaches or dizziness that disappear after you get up. Those could be your body telling you something is wrong with flow while you're lying down. That's it. No panic. No dramatic lifestyle overhaul. Just a few degrees of change, literally, that could spare your arteries from hours of unnecessary mechanical stress. Practical takeaways you can use tonight. Here's a checklist for safer sleep posture. Times: lie down on your back. Is your chin pointing at the ceiling or tilted up, down? Adjust pillow thickness so your neck is neutral. Times: turn your head slowly to the left and right. Do you feel any stretch or strain? If yes, your range of motion during sleep should be less than that. Times: if you sleep on your side, have someone check your spine alignment from behind. Shoulder to ear should be a straight line. Times: avoid sleeping with your arms stretched above your head, the Superman pose, if you have thoracic outlet anatomy concerns. Times: if you snore heavily or have been told you stop breathing at night, ask your doctor about a sleep study. Treating sleep apnea is far more impactful than sleep position alone. The bottom line: sleep position alone will not cause a stroke in a healthy person with normal arteries, normal heart rhythm, and normal clotting function. But for the millions of people living with silent or known cardiovascular risk factors, the position you hold for 1/3 of your life matters more than most realize. Cardiac surgeons are not asking you to sleep like a statue. They are asking you to understand that your neck is not just a conduit for your spine, it's a highway for blood. And highways don't work well when they are kinked for hours at a time. The warning is real, but the solution is simple. Adjust your pillow. Align your neck. And if you wake up feeling wrong, don't write it off as a bad night's sleep. Pay attention. Your brain will thank you.